Thank you for joining us for the last session, one of the last sessions of the 2024 IDM Symposium. Thank you for ending your day here. Yes, you've made it through. Congratulations, all of us, but especially our presenters and our planning team and the IT people, right? For real. So thank you for ending your day with us. We have 3 very interesting talks lined up today, and they're really just getting at some advanced modeling and analyses and the impactful implications of data analysis related to maternal and child health. So very exciting. We have 3 speakers today, so plenty of time for lots of questions. We'll have maybe 20 minutes for each speaker, 5 minutes for questions. I'll give 5 and 1 minute warnings. A reminder to those who are participating virtually, please put your questions in the chat and I'll monitor them. And then without further ado, I'll introduce our first speaker, Dr. Isaac Latea, a researcher and data scientist from, forgive my pronunciation. If it helps, I'm a victim of it too. So he's a researcher and data scientist from Ifkara University, or Ifkara Health Institute and the Prime Health Initiative in Tanzania, joining us all the way from Tanzania. And he's focusing his research on health systems and system integration. So I'll yield the floor to Dr. Latea.
All right. Thank you very much. Yes, my name is Isaac Latea. I am from Tanzania, and I'm a researcher, data scientist. I work on software developments and system integration in the context of public health. And I am going to speak with you about a project that we received funding from Gates Foundation last year, and it's under the organization called Prime Health Initiatives. And when they got that funding, they consulted me in terms of if we could put together a machine learning model to address challenges in maternal health. So I'm going to sort of walk you through on what we did in the span of 2 years. Okay. Now, so before that, I put this image, I took it in the Google Maps, but it reflects to the situations we have in Tanzania and in many, many low and middle income countries. So this is a picture of a facility, one of the facilities. And what you see outside, those are, ANC attendants or postnatal attendants. They come to receive services. And I want you to, take a couple seconds to sort of assume yourself in that kind of situations, and you need to provide services to those women. And position yourself like that person over there. That's a healthcare provider. On her daily routine, she has to service approximately about 200 people or 300 people that they come through her doors. And she has to go outside and service all of them. Some of them are okay. Some of them have issues. Some of them have complications. And one of her jobs is to sort of try to help them out. They go through that, period of pregnancy okay. And eventually they deliver okay. And both mothers and child are fine. Now, so after putting this into context, what I put forward in my abstract proposal when I submitted to present here, this is my first sentence. And I want to unpack it so that we understand what you're trying to deal with. So I wrote, in low and middle income countries, the persistently high maternal mortality ratios, MMRs, remain significant, a big concern, yeah? And this represents the tragic losses of both mothers and infants. Many of these deaths result from preventable complications. And there are 3 things I wish to pull from these sentences. 1, low and middle income countries. 2, high maternal mortality ratio. And 3, preventable complications. Because these are sort of the basis of our model that we're going to speak later. Now, I think looking at in the room here, most of you might already know when we say low and middle income countries, what we're implying by that, yeah? Is that band over there in the middle, yeah? So those countries have these types of characteristics. You have like limited powers or electricity, it goes on and off, limited infrastructure, things like internet, roads and stuff like that, limited expertise, human resources for health, doctors and nurses, not enough of those, and dispersed or scattered population. People live in distant area, So when they come to seek for health services, they sometimes have to go quite a distant location. Now, with that, looking at that picture over there, the low and middle income countries, yeah, I am from Tanzania. I flew from Tanzania. It's somewhere right there where that arrow is coming from. And this project that I'm presenting to you was based or is based in that little part on the top part around the lake zone. That's where you find a similar of that picture we saw in the beginning when those mothers going to seek for services. You see the similar situation that they experiences. Oftentimes when we get visitors that are coming to Tanzania, they go to the big cities and you don't get to see those kind of experiences. Yeah? So big cities have computers, have air conditioning when you go to facilities. But if you move a couple kilometers inside, you start seeing those communities that they really struggle when they go receiving for these health services. Yeah. So that's the kind of situation we are attempting to address. And now you have to picture that when you develop these solutions. When you say, okay, I have a digital solutions, you have to think of those kind of people because that's the majority of the population. Yeah, over 60%, 70% of the people live in that context, but only fewer lives in a much more fine environment. No, so that's part one. So we understand where we're going with this, the type of people that we need to interact. Part two, high maternal mortality ratio. Yeah. So this is the number of maternal deaths per 100,000. So I pulled a couple countries just as an example. And the data came from the World Bank data. It's public access. Anybody can look at that. And next, around Tanzania, I pulled those two other additional countries just to put into perspective. So like Kenya, then according to the World Bank data, they say the maternal mortality ratio is 530 deaths per 100,000 live birth. Uganda is 284, Tanzania is 262. You know what that means is there are 200 for Tanzania, there are 262 mothers who die per 100,000 live birth. That's a big number. You know, I believe when you're speaking about human life, even a single death is important. Yeah. So our contribution, what we're trying to do in science is to save even that one single mother not to die in these complications. Maybe I'll take a pause and ask, what do you guys think about like the US now that we're in the US? What's the maternal mortality ratio for US? Yeah, take a guess. Yeah. All right. Fortunately, I pulled that number in there, and according to the World Bank data, it says 20. Yeah. So that's according to them. But sometimes, again, these numbers may reflect different when you pull data from the ministries of health. Yeah. But this is according to the World Bank data. It could be very closely to the reality that you might get from the ministries of health of the respective countries. All right. So that's the second part. The third part is preventable complications. These mothers are dying of preventable complications, suggesting that those complications could be prevented. And what does that mean? What does that mean? Yeah. If you look at that, I also Googled it. And what are these preventable complications in relating to maternal death? The topmost was hemorrhage. Yeah. And the second most important is this hypertensive disorder. And I want us to draw our attention to that because that's the one that we modeled in our machine learning approach. So the hypertensive disorder, by definition, there are two parts of it: the preeclampsia and eclampsia. And the definition is like that. You know, preeclampsia is a condition characterized by high blood pressure and the damage to other organs, often the liver or kidneys. If untreated, put that in quotation, it can develop into eclampsia, leading to seizures, coma, and death if untreated. So it means if you detect it earlier, if you treat it, you may be able to prevent that. Yeah. And on the other side, those are prevention mechanism or management. If you want to stop that from happening, if you want to prevent death, you could do the regular antenatal care. So these are antenatal visits, monitoring of blood pressure, early use of medication like magnesium sulfate during delivery can prevent the severe outcomes. Again, if you pay attention to the prevention mechanisms, first is regular antenatal care, which means these mothers need to be coming to facilities, yeah, for regular antenatal care. But again, picture that, the low and middle income countries, the way I said about, the distance when mothers has to walk. So that may prevent them coming to the facilities because it's far. Second, monitoring of blood pressure. So need to be taking this. So if a mother does not come to facilities, then you miss that opportunity to monitor that. So all this, if they're not putting into the picture, then it results to those high number of maternal mortality ratio. Yeah, we good so far? All right, now, so what did we do? Going back to the technological part. Yeah, and this is where my big contribution was in. By the way, I am not a medical doctor, but I had to study this first before I could develop a software solution. Before I could do machine learning, I had to first understand what's really going on in this population. That information helped me into putting together a data-driven solution. Now, so in a nutshell, this is what we did. There are 6 parts. So the first part, it began here, yeah? Establish GANG. GANG, it's a short form for Group Antenatal Care, yeah? So it's, I believe it's out there, has been published. It's a methodology where mothers of similar characteristics, they're put together and then they are being seen in a group situation, like in a group context. So instead of, let's say, seeing 100 or 200 mothers in a day, you group those in a group of 20 people and you say, you come at 8 o'clock in the morning, you come, at afternoon, you come in the evening, something like that. Because they have similar characteristics, issues of similarities, they can be discussed in a group sessions. So that's one. Now that you have mothers in group, that gave us the second part, an opportunity to provide educations. So you start discussing issues of similarity in terms of pregnancy complications, and you build that knowledge to them. Yeah, you give education in terms even to remind them to come to facility and stuff like that. Number 3 of the biggest interest to me and to the team that I was leading is to get the data. Because the solution that it's a machine learning types of a solution, one of the biggest input to it, in fact, the big part of it is data. If you don't have data, you cannot devise a technological solution or a digital-driven solution. So it's to get the data. So now you create a mechanism to group the mothers, you put them into knowledge, and then you get the data from there. Now, the data that you extract from there, you put it into now, develop a predictive model to predict these adverse maternal events. The 5th part is once you've predicted, you create a mechanism to produce that feedback to the providers. So for provider, act like a second layer to look into that feedback that comes from computer. And then last but not least, a feedback that goes all the way to the client themselves. So this is what we did. And our contribution was at that part over there where we captured data and developed the machine learning part. All right, so what did we do with this? All right, so first we joined the Ministry of Health initiative and deployed something called Unified Community System. So it's just the simple way of saying there was a system over there for capturing data at the community level. And this system is led by the government, yeah? And that system is a tablet-based that has a software built inside that at the facility level, a healthcare provider can log in, can key in information about the patients, and you can monitor. So you can record these pregnancies from these antenatal visits. And the system itself, it has adapted the national guideline, which again is the WHO guidelines for the provision of ANC services. So it has all those important parameters that needs to be captured, yeah? So we deploy a system like this. And the big part of it as well is the fact that it uses tablet. This also addresses the earlier concerns about, power problems, having deployed very high technical. This is a low-end device and can be used literally by many people compared if you had to put a computer over there, if you had to put a server system over there, that would have been much more complex for that community. So we took a device that could relate with the situation, with the context that we're experiencing over there. So we joined the initiatives and provide those tablets. We installed that software and we trained the people. We started capturing data. Yeah. So now data start to come in. Yeah. Next to that, what did we get from data? Now, because we joined that initiative, we had access to the national repository that contained all this ANC data. So we took the data, and by March 2024, when we did the data extraction, we had a total of 337,027 records. Yeah. So that's the data that we have. And this data contained multiple visits. This is longitudinal repeated visit for mothers, observation, and visit ranges from 2020 to 2024. If you tabulate those visits, the visit number, and you can see indeed majority of women's, over 50% of those only had a single visit. What that means, when you look at the data, most of the mothers in that data set only came to the facility once, over 50% of those. And this is, again, is contrary to what we are saying. If you want to prevent those maternal complications, we need to promote coming to facilities. So we need to promote these numbers to go more down. So we need to have more facility visits so that we get more opportunity to collect this information, like the predictors for these conditions. Yeah. The second part, if you also look at the data set that we contained, average gestational age was 24 weeks, so the majority of those mothers. So first you have majority only have single visits, and the majority comes at 24 weeks. So this tells majority of those mothers that came to the facility that we captured were at the 24 weeks of pregnancy. Yeah. So we did this at the initial stage. Before jumping into doing the machine learning and stuff, first we kind of doing explorative work to look into the data. What does this data tells us? Now, second part, we looked at the quality of the data. This is the biggest concerns in low and middle income countries in Tanzania when you want to use routine data to do science. Oftentimes the data is not good, of good quality. You find so many issues. And again, as I think I might have mentioned this at the beginning, this was more of an operational research. So we integrated into ongoing government processes. So the data continuously to come. So it was not like a selected environment where we did like a clinical trial or like a project, but rather integrated into these routine services. Wow, I have 5 minutes. Wow. Okay, all right, let me go faster. All right, so the data has some issues, but we had to work with it again, because in the end, we needed to predict. Now, the model itself, what did we do? So we took the data, and the first thing, based on what we wanted to achieve, we collapsed it from longitudinal visits to cross-sectional, so that we could get a mother with one record that could explain the mother rather than having multiple visits. By doing this, it also addressed some concerns about the data quality and so forth, because if you expand that into multiple visits, you may have some gaps and null values. But when you collapse it, you reduce and improve data quality. Okay. And after doing that, we passed into the machine learning. This is the very common approaches when you do a machine learning project or problems. First, you get your data, you clean up, you remove all the null values, all the bias and all the outliers. And then after that, you balance your data sets. Then after that, you get a final data set. Then you split it into 10 or 90% or 70%, whatever. And then you put it into different classification methods. We pass it over 5 of these classification methods: KNN, linear regression, support vector machines, random forest, and XGB boost. And of those, the accuracy, we measure the accuracy out of those. And the one with the better accuracy is the one that we took to move forward with. So based on these findings, the XG boost is the one that performed well, and we took it forward for the next phase. Now, next, model use cases. So after agreeing which classification method we're going to use, we put the model into use cases. So we went ahead and took the data from now the new data and defined what were the outcome conditions. Yeah. Now, outcome condition, we define the presence of hypertension disorders during pregnancy, the HDDD. That stands for hypertension disorder during pregnancy. So we downloaded about 120,000 records. Then we passed the conventional definition of hypertension disorders. When we asked the obstetricians and doctors at ANC, how do you define this? And they said, okay, there are 2 parameters that we looked at. We looked at the systolic blood pressure and diastolic blood pressure. If it's within this, if it's greater than or equal to 140, or it's greater than or equal to 90, that's the criteria. That's what the doctor looks at. So we arithmetically define this and pass into the model. And then by that, we were able to see the women with the risk were 1,725 with no risk of that. And then we took the same data, we passed into the model, the one that we developed for classification. And using the model that we developed, this one predicted that the same data predicted 12,000 with the risk, above 12,000. And with no risk, about 107,000. Yeah. So we compare, if you conventionally look at this data, you'll have 1,725. But if you pass the data that we developed through machine learning, it has more records that it predicted that has the risk of hypertension disorders. Yeah. So what does this tell us? The model over predicted 10,000. So you look at the difference between that and this. So this side is conventional, using the sort of doctor's eye. That side is through a model. So it over-predict of that. So it has the predictability in order to, it does tell or predict that their potential mothers could develop such a condition. And the 10,800, the difference between this and this would have not been captured using this conventional routine mechanism, the way doctors are looking at it. Now, among the reports that you get when you develop this machine learning model is this cross-validation reports. And one of the criteria that you use to measure the quality of your model is this prediction accuracy. So with us, it was 90%, almost 91%. And here you get a precision. For predicting the no risk, the precision was 100%. Predicting the risk was 0.14, so 14%. So a little bit less because of that over-prediction perspective. But there's also a recall. Recall is equivalent to sensitivity. So we have high sensitivity. As you can see, it's lesser in terms of precision, but high in sensitivity. And this is what we want. So you want the model to over-predict so that you give the opportunity for a doctor to second look at it. So when you have 500 patients, you can use this model to filter. Instead of looking at 500, all of them at once, then you spend the whole days in not even finishing 500, you filter that. So the idea is to use the model to filter that to a smaller number of patients. That's more manageable. And then those smaller number of patients, you pay more attention to those. So that's what we did. In the very end, we deployed the model as a service-oriented architecture. So we developed a website and put it online. And there are 3 mechanisms that you could interact with the model. One, you can just go to the website and use those predictors. There are like 7 or 8 predictors that you key in those values and hit predict, and then it gives you a feedback. The second part, if you're a researcher and you have your data in Excel, provided you have these predictors, you can hit predict, and then it gives you the feedback. The third option, if you're a machine-to-machine communication, you can go through, we call it an API layer, but simply it's just a mechanism, one computer to communicate with another computer, and it also gives you the feedback. So in summary, this is what we did. And what next is to do a model validation, which may require more resources because we want to be able to follow up those particular individuals, do a model fine-tuning and model application in routine services. My last slide is to acknowledge the people who helped to put this together, which includes the Minister of Health, the regional administration in the area that we worked in, service provider that we're seeing these expectant mothers, as well as the Gates Foundation for providing fund for this project. Thank you very much. And back to you.
Thank you. Thank you for that wonderful presentation. Any questions from the audience to start?
Thank you. One question just regarding a couple of things, right? So one, the first question is, it seems like you need to have the mother come and visit the facility at least one time to get that data. What about the other, the other percentage of women that you said like never actually have the chance to go in? So that's the first question. And the second question is regarding the use of that predictive model. I think I see that there are like 7 predictors, but as you know, like most doctors probably can memorize it within like 10 patients. So would they still need to utilize that, or they just realize to recognize those 7 indicators, and the next time they just, oh, you got 2 out of 3, and therefore I should do this. Just my questions.
Thank you. So the first part, indeed, as part of the guidelines, national guidelines, mothers do have to go to the facilities in order to get those cares. We do have community health workers. They do visit mothers at home. as part of the government innovation or part of government intervention, there is another version of the app that a community healthcare workers carried to the mothers when they go do a home visit. But in terms of what the government promotes is for them to come to facilities. So if it happens that they do not come and then we deploy the same mechanism using the tablets, a community healthcare worker can carry the tablets and carry and adapt those types of variables predictors into the models. Though there could be some challenges because, some of those, in order to get those value for those predictors, you may need, either commodities or some equipment and stuff like that. That is the reason that why we're promoting them to come to the facility so that you can save more mothers at once. To your second part, again, going back to that picture that I showed at the very beginning, one of the ground problems or concerns, having sufficient resources for human doctors for health, so that's also limited, as well as knowledge. So based on practice, what the doctors, antenatal care doctors, doing over there, they primarily look at those two things, pressure, in order to detect the possibility of a mother to develop preeclampsia or eclampsia. So they look at the pressure aspects. And because of that, just by looking at pressure, what the model is telling us, you could be missing these other parameters that could potentially inform your decision. But because they have so many mothers that they have to look in a very limited period of time, so this becomes a quick service that they just do it randomly. And if you do not have any clinical symptoms of developing these conditions, they can easily miss you. So by integrating a model like this, it could help filtering and allow to narrow down the situation that mothers that need more care, they get the more care. But it's rather conditioned on availability of resources, availability of those measuring devices, availability of space to put all those mothers in one place and things like that. Those create the environment that makes it difficult to look at a wide range of predictors in order to detect these conditions. You're welcome.
Thank you so much, Isaac, for this interesting work. I'm just looking at your models, your 5 models, and it's even interesting that you deployed the eventual model. But I feel you should do more, by checking more models, because this model will serve the community. So it's essential that you do more, you test more models. There's something called no free lunch theorem. You try as much models as possible. So if I were to ask, what informed the choice of just 5 models? And one of them is an ensemble method, the SG Boost, and incidentally it performed the best. So there are other ensemble methods. I don't know if random forest was there.
It was.
It was, okay. Cat Boost and other types of ensemble methods. So my first comment would be that you try more models, like maybe even 10 machine learning models and above, and then to be able to get the best. Okay. Then secondly, there's something called data imbalance. If you look at your target variable, it's not balanced. What's your target variable?
My what?
Target variable.
Target variable.
Yes.
Okay. Now, should I take both, your first and the second?
Yes, the target variable is not balanced. I mean, what's the ratio, imbalance ratio of the target variable? This is the binary classification. So there's something you can do, maybe like smooth, oversampling, undersampling, or smooth, synthetic minority oversampling technique that you can apply to the target variable so that you can balance the data, because it is known that if you go ahead and put this type of data into machine learning model, it will not yield good results. So, but I didn't see anything of such in your work, like smooth, undersampling, or other types of balancing techniques, because accuracy will not work well here. And there are some other types of metrics that you can use, even if you don't want to balance the data. So can you consider some of this?
May I? All right. Well, first, thank you very much. Those are very, very good feedback. To the first feedback, how did we select those 5 classification models? We did just a literature review, right? And then if you do that, you will get those. They will come up. So that's one way. As in my last slide, this work is not finished, and it's pending for more modification and more improvements. So I'm accepting that feedback, and it's quite positive, and we're looking forward to do a fine-tuning of the model and continuously to improve the model. But then to your second question, how did we select these variables and predictors? I don't know if I got you correctly, but it sounded to me like you began from the model and then selecting the predictors. To us, the big problems in the nature of the work we do, especially if you deal with the routine data, is data quality. And if you first look at the data, in fact, it may not inform your model, it may do all the issues that you're saying. So we began by first looking at the data to inform what model to use, and to what models to try. And we had to do a lot of cleaning at the initial stage. In fact, the first 6 months or even 1 year, we couldn't even put our hands onto the data because we had, the integration with these routine operations. You had to go at several layers of getting permits, government approval, stuff like that. So the initial start until we gained momentum was quite, a hike step. But then the minute you get your data, it had so many, emptiness, quality issues, a lot of that. And if you take a look at lots of these routine data, that's a typical problem that you come across with those data. So we picked those variables, the predictors, based on availability of those predictors with the data. So we first say, okay, now we have, for example, blood pressure. Is how comprehensive is this variable responded? Could we use it? So if it has a lot of null values, a lot of biases, we say, no, we cannot use this variable. Then we move on to the next one, the next one, and the next one. So the original data set had over 200 variables that we could use. But again, 75% of those we could not use. So we had to first just remove it without even considering which model we are going to use. So we first had to deal with the data, then we move on to the model.
But talking of data imbalance.
Yes.
Data imbalance. Did you consider data imbalance?
Yes. As you, there was also part of the slides over there. One of the initial thing that we did was to balance the data itself by minimizing. We began with over 300,000 records, but in the end, we only moved with about 50,000 for training the data sets. So the way we did that is in order to balance the data, that it would allow us to do these trainings. And then from the balanced data sets is when we split it from 10% to 90% for training and so forth.
Thank you so much. A very interesting discussion. We have probably lots of questions offline, but thank you so much, Isaac.